امشب مهمون نازنینی داریم. واقعا لطف کردن in a very short notice. دکتر نازیلا راد. دکتر نازیلا راد دانشگاه اصفهان تموم کردن طب. سال 1997 تا 2005 اصفهان بودم. چه شهر زیبایی، خوش به حالتون. یه مدتی بندر عباس کار کردن. بازم خوش به حالتون که یک کمکی به مملکت کردین. بعد به امریکا آمدن. اینترنال مدیسیشن رو توی البرت اینشتین آف مدیکال سنتر سکول نیویورک تموم کردن. بعد در کایزر بازم اینترنال مدیسین ادامه دادن 2016 و 17 و هاربر UCLA. بعد ساب اسپشیالتیشون که میشه نورولوژی و نوروسایکایتری رو در USC خوندن. She's board certified in neurology and neuropsychiatry, and she's in private practice in Torrance. And she was awarded with the best intern of the year, Aviation Award of. She's a member of American Neurology, Academy of Neurology, American Academy of Psychiatry. اگه من بخوام برم پیش یه دکتر متخصص اعصاب احتمالاً you're the best one که هر دو رو کاور میکنی. But she has multiple papers that has been published in a very good medical journal in the United States. We're very happy to have you, Khanum Dr. Rad, and please stay. And I really wanted to hear the sleep. And she's going to go through this whole sleep pattern and the sleep disorders.
بله، با عرض سلام خانم دکتر مدنی، با عرض سلام خدمت همه شما شنوندگان و هموطنان عزیز. من همینطور که خانم دکتر مدنی فرمودن، من دکتر نازیلا راد هستم، متخصص مغز و اعصاب و ساب اسپشیالیتی این نوروفیزیولوژی، کلینیکال نوروفیزیولوژی. Is there? I just wanted to make sure everybody, all the audience are Farsi speaking. Should I talk in Farsi or in English?
So far, I'm Farsi speaking. Oh, but there's a Joe, Mr. Joe. Are you speaking only English? Hello, Mr. Joe. جواب ندادم. Well, let's start with mix and see what happens, or whatever you're comfortable. Whatever we all speak English.
So if it's possible, I'm gonna share my slides. Do you see my slides?
Not yet, Khanum. Oh yeah, we do. We do.
Okay, great. Okay, خیلی ممنون از وقتی که در اختیار من گذاشتین تا راجبه تاپیک اسلیپ صحبت بکنیم. Sleep is a very extensive topic in medicine. Two specific specialty usually work with sleep disorders, pulmonologists or lung doctors, as well as neurologists. So in neurology, there is a specific subspecialization in sleep. So you can imagine they have to spend like a year of training to be subspecialized in a sleep disorder. As a clinical neurophysiologist, I had the opportunity to work in sleep labs and work on sleep studies and sleep architecture. So here I want to talk about basics of sleep physiology and some of the common sleep disorder that we see as a clinician very commonly in society. Please write down your question at the end. I'll be happy to answer your questions. And then let's start with sleep and health. we want to know how sleep changes over the lifespan, and is that correct? As we get older, we need less sleep, or we have more sleep disorder as we get older, or how does sleep affect our overall health? That's the main question, and what we can do to have a better quality of sleep. So sleep, as probably everybody knows, is one of our essential component of our health, like nutrition that is essential for us to be alive. Sleep is also essential for us to be alive and can perform our physical and daily activity. So I want to talk a little about sleep physiology. So what happens when we go to sleep? As you know, sleep is a rapidly reversible state of reduced responsiveness. So when we sleep, we are not responsive, but it's different than comatose patient. When they are comatose, it's sometimes irreversible, but sleep, it's reversible. So you go to sleep, you are unresponsive, you don't have any motor activity, and then you wake up and you are back to your normal. And then during sleep, there are changes that happens with our hormones, with our metabolism. So these are important topics. I'm going to talk a little bit about it. And as a human, we spend like third of our life in a sleep, like 8 hours within 24 hours we sleep. So it's a big chunk of our life we are in a sleep. And we need to know what happens during a sleep, that sleep is so essential in our life. So they have done a lot of studies in sleep. They have, there are multiple researches, and it still is ongoing, because they are still things that they don't know about sleep. But in general, they know that sleep, as you probably also know, is important for our memory consolidation, for our physical activity, and is restorative to our life. So what exactly sleep does on our body? So it optimizes our physical health. When we have a good night of sleep, when we sleep well, the next day we feel refreshed, so we can do our daily activity. And you have all experienced, if you don't have a good sleep at night, the next day you are fatigued, you have difficulty performing your daily activity because of just physical fatigue. And then also sleep helps us to have a better mental health. When we have a good sleep the next day, so we are happier, we are less irritable, we have more attention, more concentration, versus if we don't have enough sleep the next day, we may do mistakes because we don't pay attention to things, or we can't concentrate. So that's why sleep is important in our mental health as well. And also immune function can get affected by our sleep. The other thing that I see as a neurologist a lot is a memory. Memory function is get affected by sleep. So if we don't have a good sleep at night, the next day our memory is not going to be good. So many of patients who come to me as a neurologist, they have complaints of memory issue. And when we get more history from the patient, majority of them, they don't have a good night's sleep. And that's why their memory or cognition is not well enough. So then the studies shows that in like surveys and a study they've done in the United States shows that like third of the population, like 30% of adults in the United States, they get 6 hours or less of sleep. And then that short duration of sleep can affect many things in our body. So the metabolism can change when we have shorter duration of sleep. We can get obese. So because the metabolism slows down, so obesity is one of the major problems. And then the other thing is cardiovascular disease, because also the metabolism change, we are more prone to have cardiovascular problem. As you know, the poor sleep causes daytime sleepiness, can cause car accidents, or injuries at work. It can affect our attention and concentration. If a child or a kid doesn't have a good night's sleep, then they are not performing well in a school. It can cause poor motivation. And as I said, physical fatigue is one of the major side effects of poor sleep, and lack of energies and things that we see with poor sleep. So how the sleep gets managed in our bodies, so how we go through a sleep and wake cycle. So we as a human, there is a master clock in our brain, in our deep brain, called suprachiasmatic nucleus, that controls this sleep-wake cycle. So it's not just the controlling of sleep and awakening, it also controls several hormones, our appetite, our body temperature. So all these go hand to hand and gets controlled by that part of the brain. So how this happens exactly? So I have a schematic here in my next slide here. You see, as the sunlight comes through our eye, goes to the brain, that big clock that you see in the center, and that big clock modulates some neurotransmitter and helps us to be awake. And opposite of that, at night, when it gets dark, just the darkness modulates some other neurotransmitter, which melatonin is one of them, and helps us to sleep. So that's how the sleep-wake cycle works in our body. So and helps us to have more drive for a sleep at night, especially later half of the night, that which maintain the deep part of the sleep, which is essential for us to be alive. And then also that wake sleep cycle helps us to adjust our timing. So you all have traveled or you crossed the time zones and have seen the jet lags, for example. So when here is morning and then you travel, for example, to Iran and it's night, then your sleep cycle gets disturbed, and then it takes time to get adjusted to that new environment. But this is something that created the way that it gets adjusted with the light and darkness. And then the time cues like Zeitgebers are the one that adjust this sleep-wake cycle. And then that most important Zeitgeber is that environmental light and dark, which adjusts this circadian rhythm. And the disturbances of circadian rhythm, it affects our sleeps, which I'm going to talk about it shortly. So the other thing that gets affected in our sleep is hormones. So some of the hormones in our hormone secretion happens during our sleep. So one of them is our growth hormone. So the growth hormones are increased during the deep stage of sleep. So in a sleep, we have part of the sleep is a very deep part of the sleep that we cannot wake people up. If we wake people up during that part of their sleep, they are very confused, disoriented, they don't know what's happening. And that part of the sleep especially, it shows that goes hand to hand with the growth hormone. And they have seen that patients who have, like for example, they were in war and they have post-traumatic stress disorder, or they had a very bad experience and they have PTSD. So they can't have that deep part of their sleep because their sleep gets disturbed. And because of that, they don't have that secretion of growth hormone. And it has shown that then if you inject the pediatric patients who don't have enough growth hormone with the growth hormone, it shows that helps them to have more of that deep part of the sleep. So, you see that this circadian rhythm and then this sleep goes hand to hand with some of our hormones. And that's why sleep is very important, because it affects the other things in the body. So the other hormone that you probably have all heard of that is melatonin. Is a transmitter that um, um, helps us to maintain that rhythmicity of our circadian rhythm, the wake and sleep cycle. And then it shows that the melatonin is higher during the night time and helps us to go to the sleep. And that stage of sleep, specifically that melatonin preserve, is that part of the sleep. We call it in the brainwave test, we call it sleep spindles. And exactly is that part that gets affected by many of the sleep medication, including benzodiazepine. So patients who've been prescribed benzodiazepine are they affect that same part of this. Same part of the sleep gets affected by benzodiazepine that gets affected by melatonin as well. So, and also it has shown some patients, like patients who have blood pressure, who are on beta blockers, a specific medication like atenolol is a medication prescribed frequently for blood pressure. That patient it's shown that the atenolol decrease this stage 2 of sleep and melatonin secretion. And it has shown when you prescribe melatonin in conjunction with atenolol, for example, that a sleep-wake cycle improves. So, so some of the medication also have effect on that melatonin and cause sleep disturbances, and that's how melatonin is important for us to have that stage 2 of our sleep. So so then the next question will be like, what happens if somebody is blind? So as I showed in that the previous imaging, the light goes through our eye, and that regulates our circadian rhythm. So what happens if somebody is blind? So they don't have this part gets canceled, and then they can't. So what happens to their circadian rhythm? So they can't sleep anymore. So the study shows that when they did research on blind subjects, they saw that they have a circadian rhythm different than normal person, which is 24 hours. So they have, like we call it, free running circadian rhythm. So meaning that they have a longer circadian rhythm. And then it has shown that if you give the blind person melatonin, it helps to regulate that normal circadian rhythm for them. And that free running to prolonged rhythm can go back to a 24 hours rhythm. So that's the role of melatonin in sleep. And then also there is other hormone that has circadian rhythmicity called cortisol, which is a hormone that gets secreted from our adrenal gland and is one of the major hormones, like is our internal steroid. And then these usually rise rapidly in the middle of the night, and it's at peak in the morning. So that sleep also affects that hormone as well. So you can imagine if you don't have a good sleep, all this gets disturbed, and all this can be affected in your body. So cortisol also, it shows that usually gets in opposite of growth hormone that usually gets secreted in a deep part of the brain. Cortisol is deep part of the sleep. Cortisol gets reduced during that time, and gets secretion is more prominent in the other stage of sleep. So what happens if this circadian rhythm doesn't work very well? So why sometimes we have problem with this circadian rhythm? There are different things that can affect our circadian rhythmicity. The internal factors and also the external factor. External factors, I'm going to talk about it shortly. Internal factor, there are delayed circadian rhythm, which meaning that patients or person goes to the sleep later at night and they wake up later in the morning. So as we develop, as we grow, we have some changes, some delay in our circadian rhythm. So you can, as you all know, that the babies they sleep like 20 hours a day, and as they grow, they have less and less sleep and more wake time. So when we get to that adolescent or youth age, you've seen that the teenager, they go to sleep a little later and they wake up also later. So that's a developmental changes that happens in the circadian rhythm. And also in the people who get older, they tend to sleep sooner, like instead of 10 o'clock that normal individual or 10 to 11 o'clock that normal individual sleeps. The elderly, they say, okay, I'll sleep usually at 7 p.m. and then I wake up at 2 a.m. So that's something that happens as we get older. The advanced sleep-wake cycle happens, and with the age, this circadian rhythm gets weaker. That's why we tend to sleep sooner and wake up sooner. So the environmental or external things that can affect our circadian rhythm, as I mentioned, is one of them is jet lag disorder. So when you cross 2 or more time zone, this circadian rhythm get disrupted, because then now your day and night is different and it takes time to get adjusted. In a study, it has shown that the westbound travel has less effect and less disturbing effect on circadian rhythm than eastbound travel. And then, but this is something that can be corrected. And also people who work graveyard or shift work, they also can have this problem with circadian rhythm. So how do you know if you have, if you are getting enough sleep, if you have a good quality of sleep? So many times when patient comes to me and tells me that I don't sleep well, or I don't think my sleep is well, I always ask them, do you feel really refreshed in the morning when you wake up? That's the main question the person has to answer himself or herself, or clinicians should ask if that sleep was refreshing or not. So one of the symptoms that you may have and you may not pay attention to it when you don't have a good sleep is not just the physical fatigue that or being or having or lack of energy that makes you worry about not having good sleep. The other things that are important, very important thing, is memory. So you don't have a good memory when you don't have a good quality of sleep, or don't have a good duration of sleep. You are distracted, you may not pay attention to things, your processing speed is less than usual. And then also you may see all these changes on your daily activity that affects your daily activity. So you may be distracted enough that you don't, for example, don't pay your bills, don't do things that you routinely were doing. But now, because of not having good sleep, things gets missed in your daily activity. Then also the physical fatigue and lack of energy that I mentioned. The other comorbid disease that well recognized in association with sleep-wake phase disorder is depression. Depression is something that we always have to screen if patients or subject is complaining of a sleep problem. So I want to talk about the sleep. and talk about what exactly sleep, the stages of sleep are. This is a very extensive topic of just a staging of sleep and how in medical field we call these stages. I'm going to review it briefly just for you guys to know that when we talk about the sleep disorder or pathologies, so you have a little understanding of what we go through when we start sleeping. So sleep has two main parts. One of them is rapid eye movements, part of the sleep, and the other part is non-rapid eye movement. So we usually go to sleep with non-rapid eye movement. That's a normal cycle that we first become drowsy, which is a stage 1 of sleep. And then a stage 2 of sleep is the stage of sleep that our sleep spindle appears in our brainwave test. When we hook up the patient to the EEG machine, we'll see when they sleep, these sleep spindles happen. Usually the medications that are available works on this stage of sleep, stage 2 of sleep. So many practitioners, they prescribe different type of benzodiazepine, for example, that works on this stage of sleep. Also melatonin works on this stage of sleep. The N3 stage of sleep is the main part of the sleep that revitalizes us the next day. So it's a deep part of the sleep. Usually our respiration and cardiovascular system is stable during that part of the sleep. And this is the part of the sleep that is a very deep part of sleep. If you wake somebody up during that part, they probably are so confused and disoriented. It's so hard, first of all, to wake somebody up during that part. If somebody wakes up during that part, they don't know even who they are, where they are, what happened. They are completely confused. So the REM sleep is the part of a sleep that we dream. So when we start sleeping, the REM is very short. And as we go through the sleep toward the morning time, REM gets longer. So REM is part of the sleep that we have nightmare during that part, or we dream, we have vivid dreams. And there are more irregularity in our heart rate, blood pressure, respiration, and ventilation. The main thing in REM is that REM, when you are in REM part or rapid eye movement part, your majority of your muscle are paralyzed. So if you get a baby in deep part of the stage of sleep or REM sleep, you see babies are so floppy. So is that exactly what's happening? So that person who is in REM sleep is paralyzed. If somebody in REM sleep, when they are dreaming, they are not paralyzed and they act out the dream and they move, then that's the problem. That's the disease. If bed partner tells the person, okay, you were like bicycling it last night, or you were playing soccer in the bed. So that's the problem. Normal person shouldn't do that. When they are dreaming, they playing soccer. If they're doing it really in the bed, that's not normal. So then let's talk about the non-REM sleep, which is a deepest stage of sleep. So around 80% of the average sleepers night are the deep part of the sleep or non-REM sleep. And this is the very important part, as I said, as I mentioned before, the growth hormones secrete during that part, the immune system function regulates during that part, and also it gives us a boost to our mind. So it's very important we go through that deepest sleep. And then when we hook up the patient to the EEG machine, we see that slow waves of sleep, which are very large waves, we call them delta wave, happens during that part of the sleep. And usually that's just the delta part or the very deep part, usually is 50% of our sleep. So it's very important for us to get that part of the sleep. Then it's a rapid eye movement, which follows the non-REM sleep. And then the rapid eye movement is just 20 to 25% of a sleeper's night. And also that's also is a very restorative part of a sleep that restores our mind, and mental revitalization happens during that REM sleep. So it's very important. So I want to go through sleep disorders. So the sleep disorders are, I want to mention, just go through them briefly. So there are many sleep disorders. As I said, it takes a specialist 1 year of training to just get to know all these disorders and how they affect the patients, how they can manage it. So insomnia, as you probably all have heard of it or have experienced it, it's one of the very common complaints that bring the patients to the clinician. There are also other sleep disorders that are important, which I'm going to briefly mention. A sleep-related breathing disorder is one of the common and also reversible sleep issues. There are central disorder of daytime sleepiness. You may have seen movies of narcolepsy or cataplexy. These are the central disorder of hypersomnolence. I'm going to briefly mention those as well. And also there are parasomnia. Parasomnia are diseases or problems that happens during the sleep, like sleepwalking or sleep terrors. They also call it in Farsi like vahshat zadegi khab. Those are things that can happen during a sleep, like a sleep paralysis. And then also there are some movement disorder that happen during a sleep or upon a sleep, which are also common, and I'm going to talk about it. The REM sleep, that rapid eye movement sleep, has a few diseases. One of them is that narcolepsy. You may have heard of it. There are people in the middle of the night, they're sitting doing their work, and then all of a sudden they fall asleep. And when you hook them up to the sleep study, you see they just right away they go to REM sleep. As I mentioned, sleep starts with non-REM, and then we go through REM. If somebody goes through REM right away, that's not normal. So that's narcolepsy. That's one of the diseases we see in REM disorder. And also, as I mentioned, REM, in REM, everybody should be paralyzed. They can't move in REM. The only muscle that works is our respiratory muscle. If somebody moves during REM or act out the dream, that's the problem. That's the disease. And then also people who have obstructive sleep apnea, they may get worse during the REM because, as I said, muscle gets paralyzed. So the upper respiratory muscle here, may get atonic, and then patients may have worsening of the symptom of obstructive sleep apnea. So the obstructive sleep apnea is a very common complaint. People who have more like a larger neck or shorter neck, they are more prone to have obstructive sleep apnea. So we usually ask the patients, do you snore at night? Those people who snore loudly, they may also have apnea without knowing it. And then what happens when they have a sleep apnea? Why it's so important to diagnose it? Why it's so important to correct it? Because when you have a sleep apnea without you knowing it, you cannot breathe during night. So that sleep is not refreshing to you. So you wake up in the morning feeling that you didn't have a good sleep, you are fatigued. Also, you feel that your memory is not good. I have had many memory patients that they have had a sleep apnea. So we correct the sleep apnea and memory gets better. Or you may have high blood pressure is one of the side effects. You may have headache in the morning. So it's very important. If you snore loudly at night and your bed partner is always complaining about your snoring, and during the daytime you have extra daytime sleepiness, if you have a headache during the day, if you feel you are not refreshed when you wake up, or your memory is not very good, always seek medical attention, because this is something that can be easily diagnosed. And then with the CPAP machines that are available now, it can be corrected. There are mouthpiece. So what happens is in this schematic, you see normal breathing during sleep, the airways are open, so you can breathe normally. But in obstructive sleep apnea, the airways gets blocked, and then you have less oxygenation to the brain. That's why the next day you are more sleepy, you don't have a good memory, you have headaches. So these are the things that happens the next day. So please, if you have a snoring, just talk to your practitioner. So the disorder of hypersomnolence or extra or daytime sleepiness are a lot. So I'm not going to go through all of them, but one of the main thing is narcolepsy, which is sometimes is really difficult to diagnose, but that's something that needs to, at least people should know about it, because that's something that can be the sleep specialist, neurologist, or pulmonologist, they can diagnose this with a sleep study, and they can correct it, because it can be very dangerous. Imagine somebody is driving and all of a sudden they fall asleep, and then they're going to have a car accident. So it's important to know about it. So narcolepsy has two types. There is one type that patients also have cataplexy, meaning that they lose. The same thing happens in REM sleep, that we get paralyzed. That happens when we are awake. So when they hear something emotional, they are very surprised, or they laugh, they all of a sudden they lose the tone and they get paralyzed, so they fall. That also, plus that they fall asleep right away without any like warning. That's a dangerous thing we need to diagnose and treat. And then type 2 is just that daytime sleepiness. They don't have that part of cataplexy, meaning that they don't lose the muscle tone, they don't fall, but they may go to sleep all of a sudden, and that's something I think everybody should know, because these patients, they can be dangerous to themselves and also to the public. So if somebody has abnormal daytime sleepiness, they definitely need to see a medical practitioner. So there are also parasomnia, which happens usually in non-REM part of the sleep. You probably have heard or have seen in movies, or have had people around you that they had in teenagers, they had a sleepwalking, or a sleep like a screaming or confusional arousal. They wake up, they don't know what happened, and they don't remember any of these things. So usually they have amnesia of the event, and they have they are not responsive. So they walk, but if you talk to them, if you ask them question, they are not responsive. That also can be very dangerous, because they do things during a sleep that they are not aware they've done it. So that's something that has also needs to be diagnosed quickly and managed. The main thing is that we have to diagnose this from seizure, because some seizure or epilepsies happens during sleep, and people who have seizures, they also don't have any recollection of what happened to them. They are amnestic of the event. They are not responsive, same as these patients. And then it's important for the practitioner to see these patients and differentiate these two, because the treatment is different, but both of them are very important to be diagnosed, because can be definitely dangerous, especially these like sleepwalkers. They are dangerous when they start walking during sleep. They are some sleep eating disorder. They wake up and they eat without knowing it, and the next morning they don't know if they've done that. So I had a patient that he was waking up in the middle of the night, and the next morning he was seeing that the trash can is full of like chopped fruits, a lot of like a banana, apples without knowing it. So these are important to diagnose. And sleep terrors is different than nightmares or dreams. Terrors are like in Farsi we call it like وحشت زدگی خواب. When they wake up, they are screaming and they don't know. When you ask them the next day, they don't know what happened. They don't have any recollection of that. These are important things needs to be diagnosed. There are things I want to also mention because some of these movement disorder are very common. So many people, they have these and experience it without knowing what's happening. So there are some movement disorder that can disturb our sleep. And patient may be aware of it, may not be aware of it. If it happens before we go to sleep, patient know about it. But if it happens during sleep, usually bed partner knows about it. So these also can cause insomnia because you can't sleep because of these feeling or movements you have. And the next day you are sleepy, you are fatigued, and you don't know why you have all these symptoms. So there are many movement disorder that happens in sleep, but there are few of them that are very common that I want to mention. One of them is restless leg syndrome. Restless leg is a very common complaint I see in my clinic. So I want you to know that. So many of these patients, they don't get diagnosed correctly. And why it's important? Because patients usually come to me and they say, okay, I'm trying to sleep and then I have to massage my leg. I have this crawling or creeping sensation. I can't sleep. I have to put my legs hours and hours under cold water, under warm water, and massage my leg till I fall asleep finally at 3, 4 a.m. And then I wake up and the next day I can't perform my job. I miss stuff. And these are the things I've seen many patients that they get misdiagnosed or they didn't get correct diagnosis. They were told, okay, you have neuropathy. It was not neuropathy. This is something that you have to know about it. So the restless leg is something when you rest, as based on its name, when you rest, like you are watching TV or you are driving, for example, you are at rest, or you want to fall asleep, it starts, you start having that sensation that is not normal. It's like a neuropathy or nerve issues, like you feel ants crawling, you feel pins and needles, you feel an abnormal sensation, usually happens in legs. There are patients that involves the whole body. I've had patients that involve the hands, involve the trunk. So this sensation makes you uncomfortable. So you try to move to get rid of this sensation. So this urgency to move is a key to diagnosis. So patients, they have to move so they get rid of that sensation. So when they say, I have to go to the shower, put the cold water, put the warm water, that's not really helping. That movement is the one that helps them. So that disease is something that causes insomnia, can cause problem with the sleep the next day and daytime sleepiness, and can be easily diagnosed and managed. So it's something that I wanted to mention because it's very common. So insomnia is the main problem of this new civilized world. Many people have problem with their sleep. They either have problem falling asleep, problem maintaining their sleep, or problem falling back to sleep. So there are different type of insomnia. There are short-term insomnia disorder, and there are chronic insomnia disorder. So I go quickly. Short-term disorder are usually less than 3 months. Usually patients have a stressor in life. And once the stressor goes away, this insomnia also goes away. And if that persists, it may evolve to chronic insomnia. What is chronic insomnia? Chronic insomnia is something we see as a clinician a lot. Many patients have problem either falling asleep or maintaining sleep. And that's when they have that opportunity, that circumstances to sleep. If person doesn't have a good environment to sleep, have a baby and they can't sleep, that's not insomnia. That's because there is no opportunity to sleep. But if somebody has opportunity to sleep and cannot sleep, then that's insomnia. If that insomnia should followed by daytime consequences, patients should have daytime sleepiness, fatigue, and stuff like that I mentioned before. And the symptom usually has to last 3 months or more, and at least 3 times a week. That has to happen, so we can call it chronic insomnia disorder. So the important thing clinicians should ask patient, if do you have a consistent time to go to bed? That's important. If you one day you sleep at 10 o'clock, the other day at 2 a.m., that's the problem. So you have to have a consistent timing for a bed. You have to be sleepy when you go to bed. If you are not sleepy and at 8 o'clock you want to go to bed, then you are having challenges to fall asleep. So you have to be sleepy. You shouldn't be anxious regarding sleeplessness. If you are anxious about that, then you have problem falling asleep. And then you have to try to minimize your nap. I'm always advocate for nap in the middle of the day, especially if you need to nap, do it. But don't nap like after 6 p.m. Toward evening time, don't nap, because if you nap, then you have problem falling asleep at night. And then also, you have to make sure your environment is also not disturbing your sleep. Like if you have a baby or you have a pet and they don't let you to sleep, then these are a sleep habit that can be corrected or can be adjusted, so that we don't call it insomnia. So the other medical condition also affect the patients. Like I had a patient today that she was telling me she can't sleep, but she had other medical problem that affect the sleep. Like if you have a chronic obstructive pulmonary disorders, or you are taking some medication that are a stimulant, or like a steroid medication or some of the antidepressant medication, they may affect your sleep. So these are important to ask in history. And also, as we age, as I said, we have these advanced circadian rhythms, so we tend to sleep sooner and get up sooner. So that happens with aging. I wanted to mention about these 3 things that affects our sleep. Coffee, you all know, it's a stimulant. So if you take coffee toward evening time, you're having problem falling asleep. The cigarette and alcohol, everybody thinks that alcohol makes you drowsy. Yes, that's correct. A small amount of alcohol before evening time may help you to sleep at night, but if you have a large amount of alcohol, actually it shortens your deep sleep and you have difficulty maintaining your sleep at night. So the same thing is true about cigarettes. So many of patients who are a chronic cigarette smoker, they wake up in the middle of the night craving for nicotine, or nicotine can shorten that deep part of the sleep and disturb your sleep. So these are something people should know about it. The management of insomnia, so far it has shown that the cognitive behavioral therapy is the superior to any other management. There are medication also we use for sleep, which has to be chosen based on the patient, other medical problem, other medications. And then the cognitive approach is basically because we want to make sure patients have less anxiety before they go to sleep. They have appropriate expectation of hours of sleep. And they know that they need to go through that relaxation phase before they go to sleep. You cannot watch TV or using your phone right before sleep and then expect that you will have a good sleep at night, because these are a stimulant, and you have to have at least give yourself and your body a time for relaxation before you go to sleep. So as we age, as I mentioned before, we tend to have advanced circadian rhythm. We tend to sleep sooner in the evening time and wake up sooner in the morning. So that's something that happens in our body naturally. The total sleep time has shown that decreases by an average of 30 minutes per each decade. So as we get older, so we have 30 minutes less of a sleep per each 10 years. So, and then many of these problems that we have with aging and insomnia, as I mentioned, many of them is other medical conditions. So they have other things that disturb their sleep. Plus aging also can affect the time. And then we usually I always tell the patient, make sure you are sleepy before go to sleep. Make sure you don't use phone, you don't watch TV before you go to sleep. These are important. And then the things I want you to take home from this this discussion tonight is that how we can improve our sleep. So as I said, it's important to go to bed consistently on a set time, and you have a routine for your bedtime. So relax before your bedtime, avoid naps late in the afternoon or late in the evening. It's okay if you need nap in the afternoon, it's fine, but toward evening time, napping is not recommended. Try to exercise daily. Also, don't exercise close to your bedtime, but daily exercise can improve our sleep. And maintain the sleep environment conducive for sleep. Don't have a TV in the bedroom. Don't have stimulant things in the bedroom that may disturb your sleep. And also avoid cigarette, heavy alcohol, and caffeine toward the evening time, which can help you have a better sleep. Thank you very much for your attention. I'm open to your question.